decreased, deficient, and abnormal. Decreased, deficient, and abnormal. Okay, so we talk about some statistics are very significant, and now I want to go into wound etiologies. What are some of the causes of wounds? Here we go. Diabetic. This is a real cool photo because it's very representative. I'm going to tell you something. I like to describe this. What is the pathophysiology or the pathogenesis of diseases? If you understand how the disease happens, you'll be able to manage it effectively. So diabetes, look at this. You have a preponderance of glucose in the body for a lot of reasons. But here's what. The glucose cannot get into the cell because the glucose is the energy source for the cell. What is the key to the lock of the cell? Insulin. Very good, thank you. So if you have a deficient insulin patient, a resistant insulin patient, the glucose hangs around. So here's what happens. It gets into the nerve. It swells the nerve. Over time, that glucose comes out. What happens when the glucose comes out of a swollen nerve? The nerve scars. So can you have an effective electrical transmission going down from one end to the other? No. You have paresthesias. You have all of the types of peripheral neuropathy. These patients have peripheral neuropathy. So what is the end result of peripheral neuropathy in these cases? You have this wound because the patient cannot feel a speck of sand in their shoe. Cannot feel a speck of sand in their shoe. So they develop this, and when you take off the shoe, you say to them, didn't you know you had a wound? They said, no, I never had any idea. Never had an idea because they have a decreased or an absent nerve, correct, nerve sensation. Absolutely right. So, what we want to do is we have two wonderful products. We have a powder and we have a gel. This gel is called amorphous. The origin of the word amorphous means no shape. A, absent, morphous, shape. No shape. Here's what. We have glycerin in here. It's in a hydrogel, and it contains this collagen in here. This is great for wounds that are dry. This is perfect for wounds that are wet or exudative. But here's what I'm going to tell you. I'm going to give you a little secret. For diabetic wounds, I mix these together in a medicine cup or a specimen container. I'll take a tongue blade and I'll mix it together into a paste, and I'll scoop out that paste and I'll stick it right in here. And then I put on our secondary dressing. This also has glycerin in it. It preserves the integrity of the wound. And I can tell you, in 3 to 4 days, you're going to see islands of granulation tissue pop up. You believe me? I know you do. Because you know why? Look at this. Look at how wonderful this is. Okay, so we have a problem with these patients, but here you have a solution. We're going to hand these around so that you can see that. So whether it's a dry wound, you have the gel. If it's a wet wound, you have the powder. I like in patients who have a significant deficit of collagen metabolism, I'll put the two together. You're giving a bolus administration of collagen. The body will love it. You can never overdose on collagen. You ever hear a patient who overdose on collagen? No. So you can never put too much. All right. So now we have venous stasis. In venous stasis, the pathophysiology, the pathogenetic mechanism, is a problem with the valves of the lower extremity for a variety of reasons. So if you have an incompetent valve, the blood is going to stay in the dependent portion, and if they have a little nick, then they're going to develop a wound. Okay? Because the purpose of the valve is to prevent backflow. But in this case, we have backflow. These wounds are painful. So what I like to do is I take the gel. The gel will do 3 things. The collagen will provide granulation tissue because of the fibroblastic activity. The gel will reduce wound pain. because it forms an occlusive dressing. And number 3, minimize the potential for scarring. So now I think as a physician, I say, you know what? If I was a plastic surgeon, I would love this. 3 great benefits for your patient. Can you imagine doing a plastic surgical procedure or a dermatologic procedure and the patient doesn't have a scar? That's a major benefit. Here's what you're doing with the gel. With regard to venous stasis, no pain, great benefit. That's a wonderful benefit for the patient. Okay, can I do the same thing in arterial insufficiency? Yes, I can. What is the pathology of arterial insufficiency? It's microangiopathy. It's a microangiopathic pathologic process. Painful wounds. So again, you can use the same solution for this problem. Every etiology I'm discussing here with you this morning, here's all your solutions right here on the table. You don't have to look anywhere else. You are creative clinicians to be able to use the products to heal the wound. Amazing. Now, skin tears. We see this commonly in elderly patients because they may have nutritional problems and they have decreased turgor and mobility of the skin. So even if you're helping an elderly person change from one seated position to a standing and you happen to put too much pressure, you'll tear the skin. You can have a partial thickness or a full thickness skin tear, but all I can tell you to do is you put the gel on there and then you put this, you'll heal it in 5 days. 5 days, you'll heal the skin tear. Okay. Pressure ulcers. 4 stages. By the way, if a good test question is, I used to ask my students this question, what is the only wound etiology in medicine that is staged? Pressure ulcers. Okay? Stage 1, 2, 3, and 4. Stage 1, there is no break in skin. In stage 1, you have erythema. If you have erythema, which is the precursor to tissue breakdown, what I do in patients with erythema, I use our lotion. The lotion will preserve the integrity of the tissue, prevent breakdown. This is prophylactic. Also, patients where I heal the diabetic wounds, to prevent them from reopening, I'll use this. So this is another...
It's skin barrier or just skin barrier or there is medicine?
This has collagen in it with a little glycerin. Let me mention to you...
It's like the ointment or?
Yes, but it's a different percentage, a different level of product in here. Let me mention to that glycerin. Why do we put glycerin here? Glycerin is a very effective bacteriostatic and fungistatic agent. Because part of the problem with breaking down tissue is you have an overload of bacteria. So let's reduce the bacterial load. Let's reduce the inflammation. Remember, erythema, stage 1, inflammatory. And here's what you do. When I heal skin tears with the Amorphous gel, I'll have the patient rub this on. It's wonderful stuff. So we have this as a solution. Okay. I can put more in here and it will absorb it. Remember, 100 times its weight of exudation is forming that gel. I doubt you'll ever get a wound that's that wet. But you know what? This is what it tells you. Regardless of how serious the exudation is, look at that. Pass that around again. Put the whole bottle of water in there. 3 grams of gold dust. By the way, there is no gold in here. Okay, so you can't sell it on the open market. Gold is very expensive. But why do we call it gold dust? And I'll tell you, one of the doctors said to the nurse, "Oh, get me that stuff that works as good as gold." Wow, magaling, no? So that's why we named it gold dust. Okay, give you a little history about the products. Okay, so we see here, stage 4, exposed bone and tendon. The worst is where you have bony prominences, where you have the pressure constant on here. If you don't offload the pressure, the wounds will just stay stagnant and they'll continue to deteriorate. But in this case, if you have a capacious use this word, capacious wound,